brain behavior functioning. And what I really want to emphasize, and we're all going to be emphasizing, and this was part of the excitement that brought the three of us together, is let's think about how the pandemic, and we'll be explicit about what exposures we mean in the pandemic, from the pandemic, they're affecting the future child. So in utero, they're affecting the child postpartum, they're affecting the birthing person, and they're of course affecting the family. And then both generations, how each one is doing, the child and the parent, they're affecting each other. And so all three parts were really aims for us, all three components, each generation, and then how they mutually influence each other are part of our work. And then I've circled on the bottom here, you will see the date of this application was August of 2020, so 5 months into the pandemic. And similar to what Rebecca already said so well, I think today many of us are thinking about it, and I really want to acknowledge, what a time of fear. Some people here in the audience may have lost people themselves, suffering from long-term COVID effects. And for all of us, what a time of fear, of trauma, of a sense of losing control and the reliability in our lives. We humans don't do well with that. We really like a sense of control. So it was such a destabilizing time. And I just want to say that working on this grant together was a lot of what got me through it. And I think we all know this, but just to say it, one of the strengths of this institution and surely of this department, they're the relationships we have with each other. They may start as working relationships and stay as great working relationships, and then sometimes move into friendships. And I'm proud that we've stayed great friends, not without some great scientific debates at times, but really supporting each other and helped me get through the pandemic. Okay, we are not going to forget about the baby while we take care of the mother. This is from Kumar, who's one of the leaders of perinatal psychiatry back in the UK in the early 80s. So he was really thinking about and wanting to treat and primarily initially call attention to depression, anxiety, psychosis in the perinatal period. But he also said we have to be thinking about the child at the same time. Again, that's the dyad goes together, to be redundant. So our work is very much grounded in this DOHAD model, which also thinks about the birthing person and the child at the same time, but puts that influence back in time to the pregnancy period. Now, many people in the department have been working in this area. We have just so many luminaries in this area. I am going to go into describing what this model means. For some people, it's not as familiar. But let me just really call out Drs. Susser, Pfeiffer, Weissman, Gingrich, Talati, Spann, Lugo Candelas, Duarte. These are all people who've been working, or at least some of their work is within this DOHAD model. So again, it might be quite familiar to many of you. We're very strong in this department in this area. All right, this model, DOHAD, can also be called prenatal programming. And then as you can see, it's summarized very well in the title of this Time magazine article, how the first 9 months shape the rest of your life. And there has been psychological research for many decades suggesting that bonding and that psychological attachment and representation of the child starts before birth. But this is a model looking at the biological connection between mother, birthing person, and fetus, and making the point that the experiences that birthing person has are going to be not only phenomenological subjective experiences, but also happening on a biological level. And the mother's biology is the baby's environment in utero. So the womb is an influential first home. This is a quote from David Barker, and in many ways, he's the father of this DOHAD model. And I just really want to read quickly, as you all can read, a nice paragraph summarizing this model with an emphasis on adaptation. So recent findings suggest that many human fetuses have to adapt to a limited supply of nutrients, and in doing so, they permanently change their physiology and metabolism. These programmed, this is fetal programming, these programmed changes may be the origins of a number of diseases later in life, including coronary artery disease and the related disorders of stroke, diabetes, and hypertension. So briefly, he was working in the area of, when he says inadequate nutrition, a lot of his initial papers are from an epidemiological approach, looking at birth weight and seeing that lower birth weight was very much associated with risk for particularly cardiovascular disease 40 to 50 years later. So lower birth weight, higher risk of that disease later. And this is from which he gets this summarizing model. It's those kind of data that led into it. So then going forward about 20 or 30 years, this model of adaptation, this fetal programming, has people contributed an evolutionary perspective to it. And I think it's really important to keep this model in mind as we hear about some of the results from the research that we've been doing, and try to keep that lens on the findings, and it may lead to some questions that you all have at the end. So the updated model, if you will, is prenatal maternal experiences, their exposures, and they forecast the postnatal environment. So the fetus responds with adaptations to improve the fitness to a later stage in development. So the health outcomes may result in part from a match between the prenatal and the postnatal environments. So for Barker, working in an area of inadequate nutrition and low birth weight, a mismatched environment would be plenty of food, particularly high caloric food postnatally. And what has been supported both in human and animal studies since he first laid out this work and based it on epidemiologic studies, saying this very, very briefly, is that an inadequate nutrition environment in utero gets the fetus to turn on thrifty genes, to store calories better as a way to survive in an environment where there's not enough food. But if you come into an environment that is a mismatch between the prenatal and the postnatal, and there's plenty of food, but you've got your thrifty genes turned on, you're storing too much fat, contributes to metabolic syndrome, contributes to those cardiovascular disease, et cetera, that cascade as you're older. So in brief, that's the model, focusing on adaptation. Oops, we didn't get the added note here. So it's a little bit different than, and actually rather different than a teratogenic model, which is something bad happens in utero, you're exposed to something bad, and like a sledgehammer, it affects your development to have a bad outcome. So I think as you listen to our work in combo, it's, to me, very important to keep this adaptation model in mind. It speaks to thinking about development on dimensions. It's more similar to RDoC. It speaks to the tremendous plasticity of development and the opportunities for intervention and change. So many of us across the globe started wondering, instead of an exposure being primarily with a focus on inadequate nutrition, what about maternal mental health issues that, of course, are also happening on many biological levels? And what might those mean for neurodevelopment and mental health outcomes in the next generation? So just quickly to say, one of the major challenges to that model has always been shared genes of risk. If you have a mother who has high levels of anxiety and you as a child have high anxiety, and she was particularly, very, very anxious during pregnancy, isn't it just shared genes of risk? One way we've always been able to counter that critique is by, more basic science studies. So for decades, there's been work, showing that when you take dams and you can randomly assign them, right, they have the same genetic background. Some of them get stressed during pregnancy and some don't. The offspring of the group that gets stressed has enhanced neuroendocrine response to challenge, increased levels of anxiety, more depressive-like behaviors, and cognitive impairments. And P.S., in thousands and thousands of papers, this is very consistent with what's found in the human studies. And then there just was a paper that came out at the end of 23, and I was really honored to write a commentary about it, using the polygenic risk score approach in the child and looking at genes of risk for ADHD, anxiety in particular, which are two of the outcomes seen most often when there's high anxiety and depression in pregnancy, and really showing that they're independent effects. So there's the polygenic risk score, contributing to the higher rates of psychopathology, but that maternal anxiety and depression are also independent, even when you control for that polygenic risk score. So we can, still there's more to discover, but I think we can feel confident that the prenatal distress is affecting the child in utero. So one last slide for me is to say another exposure that can be happening in pregnancy and potentially affecting the future child is maternal immune activation. And of course, Marissa Span is doing a lot of work in this area. We know from that Zika is associated with language deficits, and influenza, rubella, polyvirus, herpes simplex virus, HIV are all associated with psychotic disorders in adulthood. So they were exposed in utero, their mothers had these viruses, and these are the outcomes. There were few at the time of our thinking about this grant, few documented cases of SARS-CoV-1 or MERS during pregnancy, so limited data, but lots of questions. These viruses likely would initiate immune activation in the mother, and what would that mean for the developing brain? And of course, there also been not only the kind of lab work that I've been doing and others have been doing to look at these clinical studies of stress or depression in pregnancy and effects on the future child, but there have been natural experiments where people have looked at stress exposure from famine, natural disasters, war, and seen associations with risk for schizophrenia in the next generation, language and cognitive deficits, and difficult in infant temperament. So putting together the background I've described, maternal immune activation as an additional exposure, potential exposure, along with maternal stress or anxiety, we really came up with questions for the COVID-19 pandemic, because it too, of course, is a natural disaster. So with that, I'm going to pass it on.
Hi. Hi, everyone. So happy to be here. So I will first orient you a little bit to our initiative and how we've been tackling some of these questions. So as you heard from Rebecca, I work in the nursery, and I do that because it's fun. I play with babies all day long. But as Rebecca also mentioned, today is the 4-year anniversary of March 13, 2020. And that is a day that is really imprinted in my mind, because that is a day that in the US, the first woman in labor was diagnosed with COVID-19. And she was diagnosed in our nursery. So the world, or at least the United States, was really looking towards us to actually write the book on how we would handle this generation. And at the time, Catherine and I had not yet become really good friends, because as she mentioned, we became really good friends that summer. I turned to the literature, and in particular, this one study on the 1918 Spanish flu really affected what I've been doing for the last 4 years. And this was a study looking at the generation born during the height of that pandemic, which was from 1918 to 1920. It was about 2 years. And they compared that generation to those people born in the preceding 2 years and the 2 years after the pandemic. And what they found was that they had increased risk of things like kidney disease, circulatory and respiratory problems, consistent with the DOHAD model that Catherine was discussing. They also had 5% lower salaries and a 15% increased risk of being poor. But what really struck me, what really mobilized me, was that they also had a 15% lower graduation from high school, right? So something that happened to them in utero 18 years prior was affecting how well they were able to perform in school in high school. And so we very rapidly mobilized. I'll tell you a little bit about the initiative. The very first dyad was actually enrolled on May 26, 2020. And in fact, at the time, the quickest thing I could get through the IRB was for us doctors to actually call. So Rebecca actually made phone calls to some of these patients that we had discharged from the nursery, along with a couple dozen physicians. Within a couple months, we were able to put together online surveys, and in fact, get rid of the poor physicians who were already overworked. And in fact, around the same time, Catherine's team, only about a week after us, enrolled the first pregnant individual. And in the summer of 2020, we got together, and that's when we became Combo. After that, we started adding lots of surveys, and we've basically just been chasing these children. Our last survey now is at 36 months, and we are just about to launch, hopefully in the next few months, a 4-year assessment. As funding started coming in, we also added additional components. So we had a biospecimen component for a while. We've added lots of video visits. We added brain MRIs for both mom and baby through the R01 that was mentioned earlier, as well as cooler things like olfaction testing. We also allowed dyads to enter at any entry point so as to really capitalize on this unprecedented sample. And we've been really generously funded. The first year or so, we didn't have any funding, but we were able to rapidly get funding just because we were one of the first cohorts to really get started. This is our picture from the very first year. So these are all folks that contributed to that initial mobilization. We're still working on updating this. It's actually a lot harder than you can imagine. But by now, we've had about 200 researchers that have contributed to this work. And I really want to highlight somebody who's no longer contributing, but this is Maggie Kyle. And she and I literally for 3.5 years did all of this together side by side. And we're very lucky because we were able to retain her and she's now in medical school here. I'm not going to go through this list, but just to point out that we studied lots of infant outcomes, lots of maternal outcomes. And as Catherine mentioned, our particular focus, the three of us here today, is really on this very dyadic approach of looking at mom and baby and how they influence each other. We are a consortium, so we're always looking for people to join us. You're absolutely welcome to. This is Maisie. She was our first combo baby. She is Lauren Shuffrey's baby, who was actually born at the height of the initial wave. We have now enrolled almost 1,600 dyads in total. We have about 80 unique surveys, about 27,000 unique variables, about 25 million data points at this point. We have about 2,000 videos of over 1,500 hours of footage in the home. I stopped being able to count our presentations and quite a few publications. We also are kind of an engine for academic pursuits as well. So we have 3 K99s that have been submitted with this data. One has been awarded to Morgan Firestein, 3 T32 holders, and I also stopped being able to count how many theses from undergraduate and master students we have now amassed. In addition, as I mentioned, we really are a consortium, and this is the current, an image that was put together by one of the current combo coordinators, Marissa Lanoff, just to show some of the projects that we have enabled that have nothing to do with my own personal laboratory. In addition, I want to really give a big shout out to two combo members, Sabrina Hyman, who is now in medical school, and Esther Greenman, who is still one of our coordinators, have been putting this play date together for 3 years now, right here at Haven Plaza. It's a yearly event. We do a lot of fun things. There's about 300 people that join us from the community and about 50 volunteers. And in addition to the fun things, we also do really important things for the community, things like training people in CPR and naloxone administration and even blood pressure screenings. Most of this is actually funded through our incredible outreach by members like Sabrina and Esther. Last year, for example, we were able to gather about $15,000 in materials. And if you want to take out your phone, I'll put that QR code one more time at the end. But it is happening April 7th, so really soon. And anybody is welcome. When you do that QR code, you will also see the whole flyer, and you're welcome to share it with anybody, like patients, for example. All right, so that's our initiative. That's the overview of everything that we do. So today I'm going to be talking about some of the stuff that is actually part of my team and my own work, and that is the neurodevelopment of the COVID-19 generation. Now, as I mentioned before, Catherine and I weren't really friends quite yet when the pandemic started. And my image as a pediatrician working in the nursery of what could happen was this, right? So Zika had happened just a few years prior to this. And as a pediatrician, this was my worry, right? And parents were turning to me asking me what would happen to their children. And I had, of course, no answer for them, but this was my big fear, right? And we know that particular viruses have particular signatures for what could happen. So, for example, several viruses can increase the risk of autism. Flu, in particular, has been associated with an increased risk of schizophrenia. H1N1, a type of flu, has been associated with impaired motor development and increased fussiness. And really interestingly, HIV exposed uninfected infants do have some developmental impairments, such as motor and language development impairment. So the first piece of data that I will show you is on evaluating neurodevelopment at 6 months by parent report, and this was led by Lauren Shuffrey and Morgan Firestein from the Bill Pfeiffer team. And we used the ASQ3, which is a parent report of a variety of domains in terms of development of the child. You can see them there. It is administered in English or Spanish. And in this particular initial assessment, we looked at 255 infants, 141 who were not exposed, and we're pretty certain about exposure in our sample. I'm not going to go into it. And 114 that were exposed in utero. And this initial work was really looking at that first wave of the pandemic in 2020. This was published about 2 years ago in JAMA Pediatrics. Now, what do we find? So first, to orient you here, these are the 5 domains of the ASQ: communication, gross motor, fine motor, problem solving, and personal social development. And in blue here for the rest of the presentation are the unexposed infants. And here you can see each dot is actually one infant's score, and you can see a nice big heterogeneous group in terms of scores. Now, how many people here, and people on my team are not allowed to raise their hands, how many people here think that there is going to be a signal? Hands up. We're going to do participant. All right, so not including my team, which is huge in this room, about 50% of people think that we would see some signal, right? So did we in combo, but we saw absolutely no signal whatsoever. And believe me, Morgan and Lauren and I literally milked this data in every way that you're not allowed to milk data in science, and we still could not find any difference. But of course, that is parent report, and especially during a pandemic, it's very hard to interpret parent report, right? And so the gold standard, of course, in neurodevelopmental assessments are observational assessments. But because it was a pandemic, we did not want to bring these babies in, right? And so we took a page out of the NICU follow-up clinic, actually, developmental behavioral pediatricians helped us set this up. And this is called a DAISY-2, or Developmental Assessment of Young Children, second edition. And this is similar to a Bailey for those of you who have heard of that kind of assessment, but can be much more easily adapted to be done via telehealth. And so we did all of these assessments via Zoom. We did these as well in English and Spanish. And in total, what I'm going to be showing you is data from an impressive 407 infants assessed during the pandemic. And, just put that into context of what you generally see in terms of actual observational assessments that take an hour. That's pretty impressive to be done during the height of a pandemic. We had a total of 258 that were not exposed, 112 that we know for sure were exposed during pregnancy, and 37 that were mom either had COVID prior to the pandemic, prior to pregnancy or an early pregnancy. We also expanded the window of time. So here I'm going to be showing you babies that were born anywhere between March 2020 and November of 2021. And really importantly, we also expanded geographically outside of New York into Utah and Alabama through a CDC collaboration. And this paper is also published now about a year ago in JAMA Network Open. And you can see the two co-first authors flip-flop there, with Morgan being first. And before I show you the data, I just want to show you a little bit of what this looks like and the ecological validity that we're getting through this assessment. So here's a short clip.
So next we're going to use that blanket again, and you can grab any toy, and I want you to partially cover the toy with the blanket. So you can place the toy on the ground and then like hide it so that a bit of it is sticking out. We want to see if you'll pull the cloth off and find the toy.
Oh yeah. Here. Ready? Where'd it go? Where'd it go? You know where it is.
Yeah.
Oh, here.
Great, that's perfect. Now you can do the same thing again, but cover it completely.
Okay. There it is.
So you can really see two things there. One is the ecological validity, and two, why I attract so many trainees to my lab, because they get to spend time with babies, which is always fun. All right, so now for the data. So first, orienting you again to the unexposed group here. This is an interesting assessment because it's normed, kind of like an IQ test. And one of the nice sanity checks is that, as you can see, all the negative babies hover right around 100 in terms of their mean, except in the cognitive domain, which is actually a lot higher. So there's sort of two interpretations that we've come up with, although you can probably come up with many. One is this ecological, more relevant environment, right? Because these babies are in their home, they're probably a lot more relaxed there. But two, it could also be that these babies are primarily from New York, right? So who knows? So how many people think that now with this much more deep phenotyping, expanded geographic and sample size, we see a signal in terms of neurodevelopment? Hands up. All right, I think aside from my group, I see about 25% of people. We saw absolutely nothing. And yes, we milked this data too. And we used all kinds of covariates in all kinds of ways. But as you can see, I mean, from the distributions here, you can really see that there's absolutely no signature whatsoever. Which is really reassuring. But of course, that's 6 to 12 months. We've looked at really early development, as we have talked about, both Catherine and I. You can see things that come much later in life and not necessarily show up in infancy, right? And so because we have continued a lot of these assessments, we now have over 300, I believe, videos from the age of, actually, I think more, from the age of 2, and we're continuing to use DAISY2, continuing to do these over Zoom. Here I'm showing you data from about 250 assessments at this age, so at 24 months, and this is led by the other combo coordinator right now, Imal. So now we're looking again at the unexposed group first. You're seeing, again, this nice sanity check that we're still kind of hovering the mean around 100. And how many people think that at the age of 2, we're starting to see a signal? All right, maybe 20%. Absolutely nothing. It does look like in the cognition there's a trend, but after adjustment, it does not actually, for covariates, it does not actually maintain. So really reassuring data. And, this is one of the times in science that, first of all, it's wonderful to have negative data, which is, you can't say that too often in science. But two, as a pediatrician, I actually get to create the data that I can reassure parents with, right? So now when I work in the hospital, I can actually tell the parents that it's okay when you have COVID because, so far we don't have, of course, there still can be other things that show up, but so far we really don't have anything to worry about. But I didn't tell you the second part of that initial paper on the ASQ, which is that we also were very lucky that Lauren Shuffrey in Bill Pfeiffer's team had gathered some data from a historical cohort of babies born in the 3 years preceding to the pandemic. And because these were also born here at Columbia, we had this really nice cohort to compare to because basically everything was very similar for that sample. And so here what I'm doing is I've pulled together the pandemic born babies now in purple. So these are the combined unexposed and exposed infants that were born during the pandemic in that initial paper that I showed you. And now we're going to compare them to 72 babies born prior to the pandemic. And now all of a sudden what we're seeing is that we are seeing some decrements. They're small. These are only a couple points. Nevertheless, they are statistically significant in gross motor, fine motor, and personal social scores, right? When you think about it, and I'm sorry, this showed up in the wrong order, but when you think about it, right, in a never-ending pandemic, this can actually mean quite a bit at a population level, right? And so here, what I'm showing you is just the first initial look at looking at that first cohort of babies born at the height of the initial pandemic in 2020 versus babies that are born a little bit later. Most of these babies included in this particular graph were born in 2021. And what you can see is this nice recovery, right? So on the bottom graph, I've pulled down again the babies born during that first wave, so in the top graph, and now we're comparing it to what we're calling here second wave babies, and we're seeing this nice, we can't call a recovery, but this nice higher scores for the second wave babies. And in fact, when we compare these second wave babies to the historical cohort babies, we see very little decrements, only a slight decrement in the fine motor. So that's, for the most part, really reassuring data. But these babies are aging into various critical periods, right? So another period that we're worried, another thing that we're worried about now is autism risk, right? So they're starting to age into the the age group where we can start diagnosing autism. So this was something that I was very, very interested in studying from early on in the pandemic. So here I'm going to be showing you data from the MCHA, which is the Modified Checklist for Autism in Toddlers assessment, the revised version. And this is led by 4 very talented, 3 postdocs and 1 PhD student. This is really importantly a screener, not a diagnostic tool. So we're not yet at the point in the pandemic where we can talk about diagnoses. In terms of scores, a score above 2 is telling us that we have to monitor these babies more closely, and if they score above 2 a couple of times, then refer them. It's, again, can be administered in English and Spanish, and it's administered between 16 and 30 months. But really importantly for this particular study, because this is used both clinically and in research, and because here at Columbia there was an implementation of universal screening in February 2020, we're also able to look at both clinical scores in Columbia clinics as well as combo at the 18-month survey. And we've just meta-archived this, so we've just pre-printed this study if anybody is interested. And it was just submitted. All right, so first I'm going to be showing you, so again, everything I've showed you so far is in utero infection, no effect, but just being in utero during the pandemic, some effect, right? So the first aim here was to look at birth during the pandemic versus pre-pandemic birth in terms of autism risk. And here I'm showing you first data from electronic health records, and how many people think that we're going to see a signal? All right, I think we've dwindled down to about 10%. Absolutely nothing. These are just about the most reassuring negative data from a huge sample size. And again, these are clinical data from universal screening. So this is really, really reassuring. Similarly, non-significant also when we just look at preterm versus term, because we do know that autism risk is higher for babies that are born preterm. Okay, so next we're going to now look at that in utero exposure, right? So several viruses, as I mentioned before, are associated with increased risk of autism. So even though we didn't see anything on the neurodevelopmental assessments, might there be an increased risk of autism? All right, last participant, who thinks that we're going to see a viral induced signal? One person. I've made you all into skeptics. Wrong. But I'm going to let that number sink in a little bit. That is not the direction that we were hypothesizing. That's exactly the opposite direction. Now, there's lots to discuss here. We do not think that COVID is protective against autism, nor are we saying that in the paper, and I'm happy to discuss at the end what we think is going on. Nevertheless, again, reassuring that COVID is not really showing us a signal. We did see this significant association in term only, but not preterm only, and that's most likely due to power. And of course, because we also have a sample of exposed and unexposed in combo, we could also look at this association in our cohort. And here we did not reach statistical significance, but it is really interesting that we're seeing the trend in the same direction. And with that, I'm going to turn it over to our third speaker.
Hi, everyone. It's so nice to be here. And thank you, Dani. So I'm going to be talking about the intergenerational transmission of stress in this sample. And what's important to note, and Catherine will be happy that I'm saying this very clearly, what I'm talking about are postnatal assessments, not prenatal assessments for the most part. Jen Warmingham, postdoc working with Dani and me, pointed out this article that recently appeared in the New York Times about poverty increasing, especially in New York, with children bearing the biggest brunt. If you look on the left, you see trends in the prevalence rates of food insecurity over the past few years and how that's pretty steady and increasing, right? We also know from previous research that food insecurity predicts internalizing symptoms in both preschool and school-age children. And we also know that economic hardship, neighborhood disadvantage is associated with the altered functional development of prefrontal cortical regions that support higher order processes. So this is just important as background to show you what we've been doing with this postnatal data. We have been looking at food insecurity in those assessments that Dani described. This is when we acquire data on food insecurity. You can see in the red here. And then we also look at perceived stress in the moms at 18 months. And then importantly, we've been doing measures of socio-emotional functioning, specifically using the CBCL at both 24 and 36 months postpartum. Now, the food insecurity assessment, and this was led by Cristina Hernandez in Pediatrics. And we've been working with her on these papers that we're working on now. And you could see the questions within the past month. Have you worried that your food would run out before you got money to buy more? Within the past month, did the food you bought not last, and you just didn't have money to get more? If you see on the left here, the US national average in 2022 of food insecure, people who endorse food insecurity, is less than what we have in our combo sample. Now, in this sample, what we're doing, we're looking at a subsample of 415, because those are the individuals or the dyads that we have longitudinal data from. We have CBCL, we have measures of perceived stress in the moms at 18 months and measures of food insecurity. So the sample has, been restricted a little bit, but 415. But from birth to 18 months, you see we have almost 32% of the 415 endorse food insecurity at one time. And this is really consistent with what we know about this pandemic, how it's disproportionately hit lower income, underprivileged individuals. We felt in looking at this data that this is really something that we need to investigate further. So Jen Warmingham has been leading this effort, and she's in the audience today. And what we've started doing is looking at how food insecurity might predict child internalizing and externalizing symptoms on the CBCL. And these are measures that were taken either at 24 or 36 months. Of course, there's some children where we measured both 24 and 36, but some where we only had one or the other. But what we could see here is that those who endorsed food insecurity, the mothers who endorsed food insecurity, had children with more internalizing symptoms. And this is consistent with what I showed you before, that food insecurity does predict internalizing symptoms in other samples. And this is something that we've been thinking about more and more. And in a model adjusted for the age at CBCL assessment, child sex, and COVID status, what Jen found is that maternal perceived stress predicted both internalizing and externalizing symptoms, but food insecurity only predicted internalizing symptoms. So we found this really interesting, and especially like reminds me of conversations that I've had with Kate Fitzgerald. Little kids, preschool age, they feel anxiety, they have more somatic symptoms, right? They feel it in their bellies. So this kind of makes sense, and it's something that really is worth investigating further. Given the R01 that we have, we've been scanning away. Well, before we were paused, we were scanning away, and we have been scanning both mothers and babies. Now we have a lot more data from moms than babies because we also received a supplement to scan another 100 moms. So what I was really interested in looking at is how maternal brain, the mother brain, might predict child socio-emotional functioning, and also how the mother brain might be affected by their stress and specifically their food insecurity. So just to show you the usable data that we have, we use very strict quality control criteria. These are mothers with available brain imaging data, so usable. And it was really nicely split, where we have 38 moms who were positive at some point during their pregnancy and 37 who were negative. And it just ends up that these groups were matched, both on maternal age, on their perceived stress at 18 months, and their children in terms of these CBCL scores, and also the BITSI, which is a measure of social competence for preschool children. So we've been processing and analyzing these data. And just to give you a little background, what we are focusing on is really what I'm been interested in my lab for the past 20 years. So this concept of self-regulation or self-regulatory control, which is really the capacity that allows you to control your thoughts, behaviors, and emotions and desires. And deficits in these processes characterize many different disorders that arise during childhood and adolescence. And in the literature, I use self-regulatory control, but it's an umbrella term that also, we hear top-down processing, impulse control, cognitive control, effort for control, inhibitory control, delay of gratification. Now, work from my lab and others has consistently shown deficits in these processes in children with psychiatric disorders. And importantly, longitudinal data suggests that, these task control networks, or not necessarily longitudinal data, cross-sectional data collected from healthy individuals and individuals with psychiatric disorders, that these processes are supported by these task control networks, specifically the frontal parietal network in yellow and the singular opercular in purple, and their interplay with the default mode network. So it's really like the increasing segregation of these networks that tends to support the increasing capacity for self-regulatory control in normal development. So I want to bring that up just so you understand what we're talking about is like the segregation or the balance between these task control and default mode networks. So what we found in this data set, in the 415, was that both food insecurity endorsement and maternal perceived stress predicted entanglement between these networks that are supposed to be segregated for the purpose of cognitive control in the mothers. So this is kind of interesting because these are supposed to be segregated in a healthy, functioning adult, right? But here they're entangled. And more interesting, in an adjusted model, what we found was that this entanglement predicted total problems and internalizing symptoms and attention problems and also problems on the BITSI, but only in the children who were exposed prenatally to SARS-CoV-2. So this brings us back to the idea, like we know that maternal stress, just living during the pandemic, might affect child development. But here we're thinking, well, this might have something to do with maternal immune activation. So this is something that we're looking at now, and we want to really dig into the weeds and, figure this out. And we're really, really interested in following these children longitudinally. We actually partnered with Kate Fitzgerald, child psychiatrist, and another female friend of ours in the department. And we submitted a grant recently to study these children, focusing also on cognitive control, because that's what Kate and I do, self-regulatory processes in the children during preschool age. And in that grant, we're proposing to just do electrophysiology because they're a little too wiggly to put in the scanner. And so they're going to be going through Kate's lab and doing electrophysiological assessments of cognitive control. But, what I'm trying to show in this beautiful figure that one of Dani's postdocs created for the first grant we submitted is that, we know, being in the Department of Psychiatry, all being psychologists and psychiatrists and neuroscientists, that, different psychiatric disorders have different onsets at different time points during development. So we don't know. I mean, is it going to be maternal stress? Is it going to be changes in basic needs that might predict the emergence and exacerbation of these symptoms and, full-blown disorders? Or it could be maternal immune activation. So these are things that we want to really piece together in the coming years. Yes, I was talking about measuring the neural circuits that support cognitive control in the mothers, but of course we want to do that in the kids too. And what we're doing now are these really cute remote assessments of inhibitory control. So using these very commonly used tasks, the snack delay and the gift delay. These are some combo children who, of course, their parents consented to me showing these pictures. And these are some research assistants who are helping on the bottom, helping really the parent be the experimenter. And one of the most beautiful things about Combo is that, with all these remote assessments that Dani developed with her team, these families are really invested in helping us. And the longitudinal, the way that we're able to keep these women in this study, they're so invested. And I think in part because we have them partnering with us, acting like experimenters with their children in their own homes. So with that, I mean, we definitely want to look more at different basic needs, changes in basic needs, really look more at the effects of stress in the mom and how that transmits to the children and potentially predicts the emergence of psychopathology. So, these are what we're going to be working on. So thank you very much. And I want to thank our huge team. And as you can see here, is it working, Dani? Okay. Whoopsies. No. So Dani did this really interesting thing where you could see, of the three of us, who belongs to who. But really the most beautiful thing is that this is so interdisciplinary and we all work together. Like, I'm going to be writing a paper with one of Dani's postdocs. It's been a great group effort and really just, amazing. We also need to thank our funding sources, of which there are now many. And again, this is the QR code for the play date that we're having on April 7th, if anybody wants to show up. I actually brought my own kids last time. It was kind of fun. So in this year, I might put my children to work at the play date. So yeah, we'll all be there. So thank you so much for your attention.